Hello everyone, Dr. Alex Vasquez here with the next video in our program on human microbiome and dysbiosis in clinical disease. Today we're going to focus on dysbiosis by location, and I have a special surprise for you today. Here are some of the usual notices and disclosures. Also repeated here, the fact that I've served as a researcher and consultant lecturer for Biotics Research Corporation. Some of the treatments that I discuss might be considered off-label or unapproved by the US FDA. So prescribing physicians will have the ultimate responsibility to determine appropriateness of drug prescribing per patient. We'll adhere to some of the standards of so-called evidence-based healthcare, which includes patient's preference and autonomy, clinicians' expertise and experience, scientific research, and the clinical and social conditions in which we work. As I've mentioned to you from the outset, what I'm aiming for here is a structured approach to the extent that that's possible in our understanding of the human microbiome and dysbiosis in clinical disease. And again, the emphasis here is on clinical action. I'm not trying to be or convert anyone into a microbiologist or a pathologist for that matter. What I'm focusing on here are the specific clinical actions we can take with reference to the human microbiome to alleviate dysbiosis-induced disease. I've shown you my model previously of functional inflammology. You'll find this image on the cover of most of my books starting in 2014. And you'll see that I start at the top of this diagram with the 7 main considerations, the 7 main modifiable factors that we can address in clinical care when we are addressing disorders of sustained inflammation. Going in a clockwise manner, I'll start with organelle dysfunction, including specifically mitochondrial impairment, also endoplasmic reticulum stress, the subsequent unfolded protein response, and also mTOR activation. Moving upward, we can talk about pro-inflammatory diets and anti-inflammatory diets. Multifocal polydysbiosis, of course, is the focus of this program. Also, we have to look at psycho-emotional, social, and physical stressors, xenobiotic immunotoxicity, phenotype immunomodulation, and that refers to my protocol of nutritional immunomodulation, and then finishing finally with hormone and endocrine imbalances. All of these factors can feed into immune activation, which trickles downstream, as we might say, into oxidative stress, modulation of gene transcription, tissue injury, the production of inflammatory mediators, all of which segue into the development of the clinical manifestations. And of course, that is what we chiefly have to manage. But the farther upstream we go, the greater chance we have of actually alleviating and curing many of these disorders of sustained inflammation. Looking at the functional inflammology protocol from a different perspective, we can look at this model, again starting with food, infections and dysbiosis, nutritional immunomodulation, and dysmetabolism and dysfunctional mitochondria. The acronym for those first 4 components is FIND, or FIND, and then the last 3 components, style of living, sociology, sweat as a metaphor for exercise, stress management, sleep optimization, and special considerations, whether that be specialized supplementation or surgery. Then endocrine, again, hormonal imbalances, and xenobiotic load and detoxification. And so if you put the whole acronym together, you have FIND sex or FIND set if you want to exchange the X for a T and use toxins instead of xenobiotics. As I've mentioned to you before, I have defined dysbiosis as a relationship of non-acute, non-infectious host microorganism interaction that adversely affects the human host. We want to appreciate the role that the total microbial load plays in the genesis and perpetuation of sustained inflammatory responses. And as I've mentioned to you before, we have 3 main areas of focus. Number 1, manipulating microbial populations, subtracting the bad ones, adding more of the good ones. Number 2, promoting immune defense so that the immune system does its job of controlling these microbial populations. And number 3, promoting immunotolerance. Let me introduce a different diagram, which I formulated actually several years ago, again underscoring the fact that dysbiosis is a relationship of host microorganism interaction that adversely affects the human host. Again, we have 3 main components in our treatment. These are immunorestoration, immunomodulation or immunotolerance, microbicides and probiotics, again manipulating microbial populations, and in the worst case scenario, anti-inflammatory damage control, which I'm sure most of us will appreciate. That is basically what the medical model focuses on. is appreciating that these patients are having an inflammatory response against their own microbiome and then treating them with anti-inflammatory agents, and that really does not accomplish much more than damage control while leaving the rest of these problems to smolder and fester. You've seen this diagram now several times. This is my overview of multifocal polydysbiosis, again including gastrointestinal, orodental, cynorespiratory, parenchymal, genitourinary, cutaneous, and environmental. I've shown you some of the problematic microbes, and we've discussed some of the molecular mechanisms, and I'll review this list with you again in just a few moments. When we look at how everything flows together, I think that this is an appropriate diagram for representing that. We have to consider all of the dysbiotic locations, we have to consider the major microbial molecules, the pathophysiologic mechanisms which we can adjust through diet, lifestyle, pharmacologic manipulation, and then the clinical prototypes that we see: dysbiotic encephalopathy, central sensitization, immune complex diseases, reactive arthritis, which is clearly a prototype, and I also showed you recently that psoriasis should also be considered a prototype of dysbiosis-induced disease. This slide concludes our quick summary and kind of reorientation or reintroduction, and now let's all take a deep breath and get ready for today's new information. What we're going to focus on today is dysbiosis by location. I've shown you this diagram before, and we're going to begin this process in kind of a head-to-toe manner, starting with cynorespiratory and orodental, gastrointestinal, genitourinary, parenchymal, or tissue. Very interestingly, I just saw a new article on blood dysbiosis again today, cutaneous, environmental, and endomicrobial. Another diagram that represents this model is shown here, and this was published relatively recently in Annual Review of Genomics and Human Genetics in 2012. Let's take a moment and look at this diagram, and let's look particularly at the mouth, because the mouth actually has several different microbiomes within the same location or the same anatomic container, we might say. We see a different microbiome in the areas of saliva, the gums, the tongue, and the tonsils. As you already know from some of my previous conversations, I emphasize action over testing, and that is certainly and very clearly my personal preference. What I used to say is that no patient ever got better from a lab test, and that's somewhat in response to seeing so many doctors become so dependent on laboratory analysis that they're virtually paralyzed in their clinical practices unless they have a laboratory readout to act on. So what I've emphasized in my lectures and what I'm emphasizing in this program is action that we can take on day one just through common sense, information, and a competent clinical exam. You're welcome to have a read of this page. I'm going to move on to the next one. These are some of my kind of notes to self, as we might say, that I formulated recently as I was readdressing this material. Here again, I talk about dysbiosis by location with several considerations that you might have interest in. So I invite you to take a read of this page if you'd like. I'm going to move on again to the next. I'll show you the next few pages, but I'm not going to read them word for word. Some of these are kind of notes that I wrote to myself as I was updating this material, and you may have interest in reading them. Again, I'll just show you the slide. You're welcome to pause and take a look at it, but I'm going to continue to move on so that we can address the topic of the day. What I might focus on this slide, for example, is the fact that we really need to give up the idea of understanding dysbiosis in its totality because we have far too many microbial variables. So, for example, we'll look today at a partial list of microbes and dysbiotic microbes relevant to a particular area, and you'll see that that number comes out to more than 500 individual microbes. So again, as I said before in presentation number 4, what could you possibly do with a laboratory readout of 500, 400 different variables? You're not going to be able to manage that. So rather than being focused on individual microbes, let's look at big patterns. Let's look at big clinical considerations that allow us to take action, and so that we don't remain clinically paralyzed by trying to manage too much information. I'm sure you've all heard the phrase paralysis by analysis, and that's what we're trying to bypass. We want to be able to appreciate a lot of information, but we don't want to have that information impair us in our clinical practices. Again, the focus is on what can we do in real time for the real patients that we see. We're not trying to be pathologists, we're not trying to be molecular biologists, we're not trying to be microbiologists. We're trying to have an overview that helps us in our clinical practices to address dysfunctions and imbalances in the human microbiome, and especially the inflammatory consequences thereof. So what I want to do in this presentation is focus primarily on problems, a little bit of pathophysiology, and then what are the solutions that we are going to implement in our practices to help our patients. Now, your favorite patient is, of course, you, so a lot of this information is going to apply to you personally, and I invite you to kind of take that on and let this information kind of wash over you in a personal manner, because you're going to see that this information does apply to you. So I think you'll be particularly interested in this. We're moving away from the conceptual and into the very, very practical very quickly here. So I showed you this list previously, and I think that anytime we're discussing dysbiosis by location, we could reasonably revisit this list and see which of these components applies to the location and the diseases that we're specifically considering when we talk about dysbiosis by location. Obviously, some of these mechanisms will apply more to some locations and therefore, of course, less to others, so we want to emphasize the pathophysiology specific to each location. So having said all of that, let me introduce you to today's quiz question, which I posted recently on the internet. Some of you may have seen this. Which of the following clinical assessments correlates reliably with subclinical mitochondrial dysfunction, inflammation, and increased oxidative stress? Head and neck exam, for example, including earlobe crease for those of you who look at some of the more subtle details, visual acuity and visual fields, hearing acuity, mouth and throat exam, including dental exam, mouth odor, muscle strength rated 0 to 5, deep tendon reflexes ranked either 0 to 4 or 0 to 5 if you include clonus, sensory exam, vibration, pain, hot, cold, light touch, and cardiopulmonary auscultation. Which of those would reliably correlate with subclinical mitochondrial dysfunction, inflammation, and increased oxidative stress? The answer may surprise you, so let's move on to that answer. In our conversation on dysbiosis by location, starting with video number 5, the video that you're currently seeing, I've decided to start with the mouth rather than the sinuses in this head-to-toe review. I think the mouth is the most ironic location of dysbiosis because it's right in front of you. We look at and in our own mouths many times per day, and yet we generally fail to appreciate that it is the location of one of our most active and diverse microbiomes. You don't know what you're not seeing. The mouth and skin are the only microbiomes to which we have direct ability to touch and inspect, and yet when we see nothing, we are completely oblivious to the major pathophysiologic burden that is immediately before our eyes and hands. Of course, people love to delude themselves starting every day with the health of their own mouth. Nearly everyone thinks they have a healthy mouth, but in truth, nearly all adults have periodontal disease and therefore have an increased total microbial load and as a consequence an increased total inflammatory load. We note particular relevance for cardiometabolic disease, diabetes, and autoimmunity, specifically rheumatoid arthritis. Starting with the mouth is the easiest place to start. Addressing the oral microbiome is the easiest of them all, so if you want to master the microbiome, you should start with the mouth, and I'll invite you to start with your own mouth, because most adults have periodontal or gum disease, and I'll show you some more information on that, of course, as we go through. So what I started to address in the quiz question was concepts of inflammation, oxidative stress, mitochondrial impairment, and how that relates to the mouth. So let's take a look at that data before we dive into the core material today. Here's a study from Oral Diseases 2005, pilot study of breath test for volatile organic compounds associated with oral malodor, evidence for the role of oxidative stress. As you can see here from some of the excerpts that I've selected, alkanes and alkane derivatives observed in oral cavity breath are known to be products of oxidative stress in which mitochondria produce excessive quantities of reactive oxygen species that leak into the cytoplasm and oxidize several biologically important molecules, including DNA, lipids, carbohydrates, and proteins. The abundance of volatile alkanes and methylated alkanes in the breath varies with the intensity of systemic oxidative stress. These findings suggest that oral malodor may be considerably more serious than a social embarrassment, It may also be a sign of increased oxidative stress in the oral cavity and carry an increased risk of life-threatening vascular disease. Again, this was published in Oral Diseases in 2005. Now let's look at a different publication, Clinical Oral Investigations 2010. Hydrogen sulfide is a main cause of physiologic halitosis. I showed you before that hydrogen sulfide is a mitochondrial poison, so let's look at how that plays out within the mouth and see what the consequences of that might be. Hydrogen sulfide induces apoptosis in human gingival cells, which may play an important role in periodontal pathology. It has been reported that hydrogen sulfide induced apoptosis and DNA damage in human gingival fibroblasts by increasing the levels of reactive oxygen species. What was also shown in this study is mitochondrial membrane depolarization, the release of cytochrome C, which is an indicator of mitochondrial dysfunction, caspases 3 and 9, both of which induce apoptosis, and was shown here to occur within 24 to 48 hours. Let's look at another study now, a little more clinical, from American Journal of Obstetrics and Gynecology 2004. As you can see here, bad breath odor associates with oxidative stress. A breath test significantly demonstrated greater oxidative stress in women with preeclampsia than uncomplicated pregnancy and non-pregnant control subjects. And finally here we have from Journal of Periodontal Research 2012, as you can see here, bad breath odor causes mitochondrial dysfunction and death of human osteoblasts. Hydrogen sulfide is one of the two volatile sulfur compounds that are known to be the main cause of oral malodor. The other is methyl mercaptan. Hydrogen sulfide is also known to be an etiological factor in periodontal disease. After hydrogen sulfide incubation, apoptotic levels increase significantly in a time-dependent manner. Mitochondrial membrane depolarization, release of cytochrome C, p53, and caspases 3, 8, and 9, and DNA fragmentation were all significantly greater after exposure to hydrogen sulfide, which is one of the main causes of oral malodor, or so-called bad breath, more casually. At less than pathological concentrations in gingival crevicular fluid, hydrogen sulfide induces apoptosis in osteoblasts. The molecular mechanisms underlying this apoptotic process include p53, a mitochondrial pathway, and caspase 8 activation. If you look at the microbial balance and imbalance in people who have oral malodor, you see a very wide range of bacteria, which I've provided for you on this slide, so you can look at the list. Again, anytime you want to pause the video, look at the list in detail, perhaps even take your own notes, you're certainly welcome to do that. One of the things that interested me a lot about this particular study was their combined use of both DNA-based testing and also culture method. And by the use of the culture method, they were actually able to find different types of bacteria that they didn't identify with the DNA-based testing. So part of what I'm trying to introduce to you and emphasize in these first few slides is that you actually do get clinically relevant information by performing an oral mouth exam in your patients, and if you're willing to subject yourself to the experience, even sampling the odor of their exhaled breath could give you some information. We see here that oral malodor is contributed to by the breakdown of epithelial cells, food debris, saliva, blood, and volatile sulfur compounds such as hydrogen sulfide, methyl mercaptan, and dimethyl sulfide. Also reviewed in the clinical monograph, and which we'll talk about more in future presentations, are items such as propionic acid, butyric acid, indole, scatol, and cadaverine. You might remember if you read the complete printed monograph that indole and scatol are actually pro-inflammatory agents that are produced by microbes from amino acids, and indole and scatol are directly arthritogenic. They do promote joint inflammation in particular. So again, the mouth is very relevant. The mouth provides us information about oxidized cell membrane lipids and dysbiotic bacteria that can combine to create oral malodor. Interestingly enough, also within the mouth, we see some residence there that we might not otherwise expect. Helicobacter pylori actually resides in the mouth of some patients, hence focusing exclusively on the stomach for eradication without addressing oral dental health may be suboptimal. As you can see in the conclusions toward the bottom of this page, the detection in dental plaque of Helicobacter pylori could indicate that the oral cavity may act as a reservoir or sanctuary for this organism. This also, of course, raises the possibility that Helicobacter pylori might possibly be transmitted by casual oral contact, such as kissing. So one of the questions that I've had for many, many years is why don't we address oral health within the practice of medicine? So for example, as you all know, I went through chiropractic, naturopathic, and osteopathic medical school, and at no point in time did we ever really address oral health as being a primary driver of many of the systemic inflammatory diseases that we later have to deal with in our clinical practices. So you may have seen this article published in the Atlantic somewhat recently in 2014. Title is Why Don't We Treat Teeth Like We Treat the Rest of Our Bodies? And I would actually argue that we do treat our teeth like we treat the rest of our bodies. We actually mistreat both, but the mouth is virtually ignored except for a few seconds of minimal brushing that it receives by most of us every day. Again, I think that most of us have received an inadequate education to the extent that we haven't really been trained to understand and appreciate the role of oral health in systemic disease. What most doctors have never learned about the mouth is that dental plaque is comprised of at least 500 different microbial species. Dental plaque starts to form within 1 or 2 days